Our next speaker is Dr. Christian Valenzuela. Dr. Valenzuela is a surgical oncologist here at OHSU and an assistant professor. He also co-leads our OHSU Melanoma Tumor Board, which does both melanoma and all other kinds of skin cancers. He specializes in treatment of high-risk skin cancers, melanoma, and sarcoma in particular. His lab focuses on examining the relationship between blood vessels, tissue development, and cancer development. I have the privilege of sharing patients frequently with Dr. Valenzuela and have immense respect for his surgical expertise. I'm really looking forward to hearing his presentation on new developments in our field. Dr. Valenzuela.
Pleasure to be here. Hi, everyone. My name is Christian Valenzuela. I'm one of the surgeons, one of the primary melanoma surgeons here. I've been here for about a year and a half at OHSU, and the majority of my surgical practice is skin cancer and melanoma. So that does entail a fair share of non-melanoma skin cancers. That's what we'll talk about today. I have one disclosure. A close family member of mine, my father used to work at Regeneron as a scientist for many, many years. He's retired now. So I do have a very positive view of this company. I'll be talking about one of the drugs that they produce. I have no financial positions, nor have I in the past in this company. So this presentation is my opinion. My opinion only, does not represent the opinion or position of OHSU. All right, so with that aside, we'll first talk about non-melanoma skin cancers, prevalence and death rates. You already heard from Dr. Jang a little bit about that. We'll talk about sentinel lymph node biopsy technique, which is one of the techniques I do commonly for melanoma and oftentimes for non-melanoma cancers as well, skin cancers. We'll talk about the role in squamous cell, basal cell, and Merkel cell carcinoma. We'll talk about immunotherapy or programmed cell death 1 inhibition in squamous cell cancer. And we'll talk about the sonic hedgehog pathway inhibitors in basal cell cancer. These are relatively new drugs and treatments. So first, melanoma. Last estimate from the CDC from 2020 was 77,000 new cases per year in the US, with just over 8,000 deaths in that year. So about 8,000 deaths per year from melanoma. Non-melanoma skin cancers, that is basal cells and squamous cells, that number is harder to pin down because there's no separate statistics for them. Formally, the American Cancer Society estimates 5.4 million new cases in 3.3 million people over a year. And 80% of these are basal cell carcinomas, and roughly 2,000 to 8,000 deaths per year from combination basal cell and squamous cell. Merkel cell is a lot more rare, about 2,000 new cases per year in the nation, and 5-year overall survival is about 70%. And then there's a miscellaneous category, which we won't talk today, Kaposi sarcoma, cutaneous lymphoma, and adnexal tumors, but those are extremely rare. This is a visual representation of the skin cancers in new patients and deaths per year in the US. I don't have exact numbers here because these are, again, estimates, but the size of the circles are roughly proportional to the number of new patient diagnoses. So melanoma, 77,000 new patients with approximately 8,000 deaths per year, that's in orange. Basal cell and squamous cell combined, approximately 3.3 million patients with up to approximately 8,000 deaths per year. So the number of deaths from basal and squamous cell roughly is just shy or about the same as melanoma per year nationally, but the probability of death from basal and squamous cells is much smaller. In other words, much more common, but less dangerous to life. And Merkel cell is much more rare, with death rates on par with that of melanoma. So skin cancers like spreading in one of two ways: lymphatic through the lymph vessels to the lymph nodes, same system used for self-defense against viruses and bacteria, and hematogenous, or through the bloodstream, typically at later stages. Generally speaking, if skin cancers choose to spread, they prefer the lymphatic route first. So how can we detect when this is happening at the microscopic level before it shows up on a scan or physical exam? In this technique, the surgeon injects generally two tracers. There's a small amount of a radioactive tracer and a blue pigment around the site of the skin cancer. And then both tracers flow downstream the lymphatic vessels to the lymph nodes that would carry cancer if that cancer chooses to spread. So the lymph node biopsy, this isn't a cancer scan or a detection technique. It is a technique to select the appropriate lymph nodes that would drain that particular patch of skin. And those are sent to the laboratory. It's called a biopsy, but it's not a needle. It's an actual incision and a small operation to remove one or a small group of lymph nodes. They get sent to the lab. There's a little handheld Geiger counter in the OR that leads us to the right lymph node or nodes, and it actually turns blue with the blue pigment injected. Sent to the lab, and about a week later, you see under the microscope the result of whether there's cancer there or not. The most concerning risk of this procedure in the armpit or in the groin is lymphedema. That is a swelling of the limb that can be permanent. This can happen up to 5% of the time, so this procedure isn't risk-free. In melanoma, this is a standard part of the operation when the tumor has a thickness of 1 millimeter or taller or thicker, with some exceptions. I bring this technique up here because for non-melanoma cancers, the topic of today's talk, sentinel lymph node biopsy can sometimes be used as well. And as patients, it'll be important for you to know why it is sometimes recommended and sometimes not recommended. So the national guidelines for melanoma, the most updated ones are shown here, include offering sentinel lymph node biopsy for most, with few exceptions. There's a lot of evidence to support this, lots of controlled clinical trials, but that's not the topics of today's talk. For the squamous cell carcinoma, the current recommendation is to consider sentinel lymph node biopsy for high risk or very high risk cases that are potentially curable with treatment. That's not a strong recommendation, not as strong as for melanoma to offer it. And sentinel lymph node biopsy can be combined with Mohs operation or standard excision, traditional surgery, which is what I do. For low risk squamous cell cancers, there's an extremely low risk of metastatic spread, and thus the operative risks of sentinel lymph node biopsy are not worthwhile. What are the characteristics that define the three categories of squamous cell? Low, high, and very high risk. They're listed here. These are well-known characteristics clinically and under the microscope. So if you fit into the high risk or very high risk categories of squamous cell, then you'll want to talk to your surgeon or dermatologist about the possibility of sentinel lymph node biopsy. It's important to consider this before resectional operation or treatment of the cancer, because once the tumor is already operated on, that disrupts the lymphatic vessels and makes sentinel lymph node biopsy, the tracer technique, less likely to succeed if it's done after that resection. There's frankly not very strong evidence to support the use of sentinel lymph node biopsy in squamous cell, even for high-risk lesions. These are main results from a multinational Australian-led study from 2016, studying the outcomes after sentinel node biopsy for high-risk cutaneous squamous cells of the head and neck. This is observational, not prospective, only 57 patients. But there was a significant correlation between worse postoperative survival and positive sentinel lymph node result. But again, these were very small numbers in this study. Here is a similar Japanese multi-center retrospective study with 169 patients with squamous cell cancer of the skin with disease-specific survival shown here. No difference in survival. Those are the top two lines between sentinel node positive and negative results in cases without abnormal lymph nodes found on exam or physical exam, or on scans or exam. But if abnormally large or diseased lymph nodes are found on physical exam or on imaging, the survival becomes significantly worse, and sentinel node biopsy is typically not done. So, according to this study, the more important factor for survival is not the sentinel node biopsy result, but whether there are clinically detectable abnormal lymph nodes on exam before the operation. The bottom line is for high risk or very high risk squamous cells, sentinel lymph node biopsy is often done, but shouldn't automatically be done on everyone. Since the evidence is kind of thin, it will be an individualized decision, a judgment call to look at the risks and benefits of the procedure for each patient. And with most cases, if you're at OHSU, will be discussed at our skin cancer tumor board as a group before coming to a final decision on sentinel node biopsy. By contrast, for basal cell carcinoma, although resectional surgery is the primary treatment, sentinel node biopsy is not recommended nor performed. Although national statistics group basals and squamous cells together, these two skin cancers behave very differently at the lymphatic level. Basal cells are extremely unlikely to metastasize, even the large high-risk ones. So sentinel node biopsy is not worth the operative risk of namely the lymphedema. So instead, the primary tumors are resected and the patient can undergo surveillance ultrasounds or CAT scans for high-risk lesions. To give you an idea, basal cell cancers happen millions and millions of times worldwide per year, but it has only been reported a few hundred times in the literature to metastasize. For Merkel cells, briefly, sentinel node is a standard part of the treatment because the proportion that do spread through the lymphatics is considerable, on par with that for melanoma. So what happens if a patient has metastatic or borderline resectable or unresectable squamous cell cancer? In the past, there were no good options, palliative radiation or palliative chemotherapy. In recent years, however, with the advent of immune checkpoint inhibitor therapy or immunotherapy, it's been a game changer in many cancers, skin cancer included. The most commonly used treatment we give for melanoma is Keytruda or pembrolizumab. For squamous cell cancer, there's FDA approval in 2018 for a similar immunotherapy drug called cemiplimab. Trade name is Libtayo. This is an intravenous medication given every 3 weeks. Early trial data showed a majority of patients had a partial or even complete regression of the tumors while on therapy. One published example is the top panel there before and after 6 weeks of cemiplimab. This is squamous cell. And the bottom panel is a waterfall plot showing individual patients represented each by a bar, and those in the negative territory mean the tumor shrunk. There were 3 patients all the way on the right whose tumors completely went away during the trial period. This study should be interpreted with caution, however, because this did not study survival, whether the patients actually lived longer than those who did not receive the therapy. That data should be coming out in the next few years. The other non-chemotherapy option in advanced squamous cell carcinoma is pembrolizumab, also an injection every 3 weeks, which uses the same method of action and was also approved by the FDA for squamous cell cancer in 2020. The point of this is if you find yourself past the point of what we call curative intent surgery for squamous cell, there are still options and hope for you. These medications are not problem-free. They do have side effects and potential for serious adverse events, but they are options we didn't have for squamous cell just a few years ago. Let's talk about basal cell cancers. For these that are unresectable or locally advanced, there are also new medical therapies available that weren't available just a few years ago. Surgery is still first choice, but these are cases in which it's not possible to do surgery or radiation to achieve a cure. These medications are not used in small or easily resectable basal cell cancers. And the medications are called vismodegib, approved in 2012, and sonitigib, approved in 2015. These are pills. They work against the cell signaling pathway called sonic hedgehog. I'll explain the name in a minute. This cell signaling pathway is abnormally activated in basal cell cancers. In a phase 2 trial, neoadjuvant or preoperative vismodegib shrunk the tumors and allowed for smaller or less morbid operations in 71% of patients, but recurrence rates were high at 36%. So it's not a slam dunk or a cure, but probably helpful for selected patients. Another phase 2 trial, sonitigib, was given long-term for locally advanced and unresectable cases, led to 56% of patients having at least some shrinkage of their tumors over a long-term, nearly 4 years or 42 months. This drug was tolerated well by most, and roughly a third of patients having a serious adverse event, but no one dying from the medication. And cemiplimab is also a choice in basal cell carcinoma, gotten FDA approval in 2021 for this indication. However, the first choice in basal cell is the Hedgehog inhibitors. So in the 1990s, it was almost like a gold rush where labs around the world started being able to discover and reliably decode functional genes in humans and animals. And if you discovered a gene, you get to name it. So a genetics lab group at Harvard, led by Dr. Clifford Tabin, discovered a new gene within what was known at the time as the Hedgehog family of genes, not because they were discovered using hedgehogs, but because knocking out the gene led to embryos of fruit flies looking spiky under the microscope like a microscopic hedgehog. So each new discovered member of this family of genes was named for a different hedgehog species, just kind of like a tongue-in-cheek, sort of a joke. And a postdoc in Dr. Tabin's lab, Robert Riddle, named the gene they discovered Sonic because his daughter, a young daughter at the time, loved the character, the Sega character Sonic the Hedgehog. And then it turns out this gene happens to be one of the most important genes in the human genome and in animal development. And this pathway happens to be one of the main players also in basal cell carcinoma. And now Dr. Riddle is the head of neuroscience at NIH. So just as an aside. So basically, in conclusion, non-melanoma skin cancers, we went over the prevalence and death rates, newer treatment options in non-melanoma skin cancers, including the usage of sentinel lymph node biopsy and its role in squamous cell, basal cell, and Merkel cell carcinomas, checkpoint inhibition or PD-1 or immunotherapy treatment in squamous cell cancer, and the Hedgehog pathway inhibition treatment in basal cell cancers. All right. Thank you so much for your attention. I appreciate the time, and thanks for the opportunity to speak.